Hello, Dr. Kathleen McKee here. I'm thrilled to be here talking about our Parkinson's Elevated program at Intermountain Health. I'm going to share a brief outline of my presentation, which is that first, I just want to set the stage and context for the fact that we are in the middle of what I like to call a Parkinson's emergency, but then quickly move on to our vision at Intermountain to transform this chronic condition. And a key component of that is exercise as medicine facilitated by rehabilitation, and then really aligning financial incentives to make it sustainable in the long term. So with that, I'll dive right in. As just the briefest of refreshers, Parkinson's is a disease, a neurodegenerative disease that causes motor symptoms of resting tremor, rigidity or stiffness, bradykinesia or slowness, and postural instability. It also has a profound effect on many things we can't see. Most frequently in my clinic, I treat debilitating psychiatric symptoms, severe orthostatic hypotension, delayed gut transit, and all those non-motor symptoms, the things that you can't necessarily see, they really affect quality of life. So that is kind of the briefest of refreshers of what Parkinson's is. I also have to just pause for 1 second to say that I really actually kind of hate this slide because it gives the wrong impression about the face of Parkinson's, about the people who are getting it. If you do a Google search for motor symptoms of Parkinson's, the only images you're going to find are an older white man who has stooped posture and a shaky hand, just like you see here. And don't get me wrong, a lot of older white men do get Parkinson's, but so do young white men, and so do people of all races and ethnicities, and so do women, including young women and mothers and fathers and working professionals. So lots of people you wouldn't know have Parkinson's if you saw them walking down the street. And so I just like to remind people that just because more debilitated patients in their 80s are the ones that we see and know have Parkinson's, there's actually Parkinson's all around us, probably in our colleagues and in our parents and our parents' friends and in us that we might not be aware of. So you might be asking, well, why is Parkinson's all around us? And in fact, it's everywhere because it's rising exponentially out of proportion to any other neurologic disease. So given this rate of growth, Parkinson's actually qualifies to be termed a pandemic. Not an infectious pandemic like COVID-19, but a pandemic. And that is quite scary. This rate of growth is being driven by a few factors. The first is an aging population. Secondly, there's been a decline in smoking rates. And for reasons we don't understand, smoking is protective against developing Parkinson's. But those two reasons alone don't explain the full increase in this disease. And the missing piece is almost certainly environmental. So we know without a doubt that certain pesticides are linked to Parkinson's. And the rate of Parkinson's tracks closely with industrialization. So Parkinson's as a disease was very rare before industrialization. And as countries have gone through industrialization at different decades, we have seen the rate of Parkinson's track right along with that. There are chemicals like trichloroethylene, chlorpyrifos, paraquat, and glyphosate that are all clearly linked to Parkinson's, and yet the EPA has refused to ban them. You and I can both go to Home Depot today. We could buy a carton of Roundup, and that contains glyphosate, so it's unequivocally linked to Parkinson's disease. Another chemical, paraquat, has been shown to increase the risk of Parkinson's by 150%. It's been banned by 32 other countries, but not by the United States. And in fact, our use of paraquat has doubled during the last decades, mostly on agricultural fields. And so you might be thinking, well, I'm not a farmer, I don't live near a farm, so I'm probably okay. And the bad news is, unfortunately, these chemicals are everywhere. They're on golf courses, they're on our lawns, and they're actually also in our water supply. And so I could go on and on about this, and I've really just scratched the surface here. But the reason I mention it is because it's so ridiculous that we are left trying to treat a disease we could actually prevent. What we really need is a movement across the United States and really around the world to demand that we stop use of these chemicals that we know cause neurodegenerative diseases. And so I never miss an opportunity to point this out and to raise awareness, because I think it's not just my job to treat people who already have Parkinson's, but to think about how can we prevent this disease. But putting aside this idea of prevention, once someone has Parkinson's, then what? So there are three big problems with Parkinson's care at the moment. So the first is access. Across the country, if you call various movement disorder clinics like ours, or like you'll find it at most academic medical centers, you're going to hear from them that it'll be at least a year before you can make an appointment to see a movement disorder specialist. And unfortunately, it just has to do with a major supply-demand mismatch. Not enough movement specialists, way too many patients with Parkinson's. I was initially shocked by a statistic from Medicare claims data that up to 40% of patients with Parkinson's never even see a neurologist, let alone a movement disorder specialist. But unfortunately, the more I've been practicing, the less shocked I am by that statistic. I'm willing to bet there are a large number of older patients who not only never see a neurologist, but never even get diagnosed with Parkinson's. A family may think that grandma or grandpa's tremor is just old age and never take them to see a doctor. And that's a shame, because patients often feel so much better once we start them on treatment. And a close partnership with neurology and rehab services is really essential for this. It's possible rehabilitation can begin even before a patient sees a movement specialist. As we think about access and how to treat this growing number of patients, we don't want neurology to be the bottleneck on that. And so I think we need to think of more creative ways around that current bottleneck. So more on that in a moment. The second problem I want to talk about is patient experience. There is published literature on this, but you don't even have to read the literature. Just ask a patient with Parkinson's what their experience has been like. Really, they are left to navigate a very complex system of care by themselves. And Parkinson's is a multi-organ system disease, as I showed you on that first slide. And so people need to see a lot of specialists. This diagram, which was published in The Lancet by Basblom and Michael Oken, shows an idealized version of Parkinson's care. You can see here in the middle, we have the person with Parkinson's and their family. They are the sun around which the care provider should orbit. And in that tightest orbit, they need a primary care physician and a movement specialist neurologist who are going to work really closely on taking care of them and coordinating their care. The second orbit is rehabilitation services, largely, because it is so crucial to the treatment of Parkinson's. And then that third orbit are the specialists that patients with Parkinson's are going to need to see. And we like to say, Parkinson's patients are like snowflakes. No two are alike. And so not every patient with Parkinson's is going to need to see everybody in that outer circle, but they're going to need to see some. And it's very difficult for them to navigate seeing those people and setting up those appointments all on their own. And it's disheartening when they end up with a specialist who may not be familiar with Parkinson's disease. So patient experience, not great once they have Parkinson's. Unfortunately, they also often have a horrible experience with their actual diagnosis. They're seen, often by a neurologist who says, "Oh, yep, you have Parkinson's. I'll see you in 6 months." And one of the members of our patient family advisory committee describes her horrible experience of diagnosis and how she basically lost 2 years of her life thinking her life was over when in fact it wasn't. Patients with idiopathic Parkinson's under proper treatment go on to have decades of high quality life. So that brings me to problem number 3. What is the proper treatment? Well, Parkinson's is caused by loss of dopamine neurons in the brain. We have drugs like carbidopa, levodopa, which basically replace the dopamine. And when the motor fluctuations become too severe, we'll often implant deep brain stimulation electrodes. That buys another decade of high quality life. But unfortunately, none of our pharmacologic or surgical treatments slow the disease progression. The treatment with the most evidence that it may actually slow disease progression is high intensity exercise. And I don't have time to go into all the science here, but basically this is not just exercise now and you'll prevent heart disease and stroke in 30 years. This is exercise now and you will have immediate motor benefit, and it may actually slow the progression of the disease. In terms of that immediate motor benefit, we have data showing reduced motor symptoms after just 1 session of high intensity exercise. And that's backed up by patient reports who tell me they feel so much better after they start exercising, and they notice when they miss their routinely dosed exercise. Regarding the idea that high intensity exercise could be disease modifying, what's the science there? Well, Sparks 2, which you see in the upper left-hand corner by Shinkman et al. In 2018, was a phase 2 trial. So it wasn't powered to show disease-modifying effect, but it hinted strongly enough that there could be a disease-modifying effect that the National Institute of Neurologic Disorders and Stroke funded SPARKS-3, which is the largest current investment in Parkinson's research. And it's currently happening at 26 sites across the country, including here at Intermountain. The study randomizes de novo patients with Parkinson's who don't yet need anti-Parkinsonian drugs to either moderate or high intensity treadmill training. This is the study that's going to definitively answer the question of whether high intensity treadmill training slows disease progression. But in the meantime, we know it helps motor symptoms. And so we are failing to get this proven treatment out to our patients. And so, you know, I've just talked about these 3 big problems in Parkinson's. What are we doing to address these? So here at Intermountain, we started by mapping out a hypothetical patient journey here. And you can see that it's super tiny, so I apologize for that. You might need to squint and get close to your computer screen. But you can see the timeline starts in 2002 and goes through, like 2042. So we are covering 40 years here. And at the very beginning, people have probably 10 to 20 years of a prodrome where they don't even know they have symptoms, but the pathology is actually building. And then 10 to 20 years later, the first subtle symptoms start. And then there's usually a long delay in getting into neurology, as I discussed about earlier. Then there's this period of very, high functioning, people keep working, they do fine on medication, they have appointments, ideally early with physical therapy. And they see their movement neurologist, they see their primary care physician, they see some other specialists. And then, more time goes by, that's that second squiggly line there. And then they move into the later phase of the disease where they're needing more services. And then eventually, often 20 plus years after their diagnosis, end up with an inpatient admission and eventually maybe onto palliative care and hospice. And so we've taken this journey of our patients and we divided it into 4 phases. And we want to, we're specifically working on some of these phases and pausing work on others until later. So the first phase is this diagnostic odyssey of like, well, what's wrong? Takes a long time to get to see a neurologist. We definitely want to attack that and make sure that we can increase access and start to go out and find people with Parkinson's in the community. But we can't do that until we build the infrastructure to care for them first. And that gets at the next 2 phases. So the first phase is where people are doing really well, and this is where they should be doing the high intensity exercise. The next phase is where they really should be doing a skilled maintenance in terms of physical function, swallowing, and things like that. And then the final phase, I call the end game, taking a line from, or really the title from one of Samuel Beckett's plays. And so we are really focusing right now on that phase in green, the high intensity exercise, but soon thereafter, hoping to build out the skilled maintenance phase and then simultaneously working with palliative care and hospice to integrate our care there. And then after we get the system in place, we'll go out to try to attack that diagnostic odyssey. So specifically for the high intensity exercise, what we're doing is an individualized exercise prescription for patients with Parkinson's, and our physical therapists serve as a very unique triage point into this system, and I'll get to that in a moment. For the skilled maintenance, what we are doing is building a network of specially trained physical, occupational, and speech therapists in the community to help patients closer to their home. And then all stages of Parkinson's, we have a movement neurologist. We are hiring a primary care physician to become part of our movement neurology group, and then Parkinson's nurses to coordinate care. So taking a deeper dive at that high intensity exercise phase, the way we are doing this is through these interdisciplinary days where a whole bunch of subspecialties come together at our Park City Hospital, where we have just an amazing neuro PT department, a sports performance department, and our Live Well Center, sort of our hospital gyms. And the way this works is that all patients with Parkinson's, that says HOEN-YAR less than 3, but it's actually going to be less than 4. We're going to offer this program to everyone. A certain number of people are going to decline. We're going to study the people that decline. They need sort of probably an extra intervention ahead of time. But for right now, we're going to start, with a coalition of willing patients. And they have their first neurologic physical therapy assessment with the outcome measures listed there. And the physical therapist determines at that point, yep, this patient is so early in their disease, they don't have any focal deficits, they're ready for high intensity exercise. Or, oh no, I think I'm seeing some focal dystonia here, there's some balance issues. You really need a course of restorative physical therapy before you're ready to engage in high intensity exercise. And so if they end up going that restorative route, they do their physical therapy and at that point determine you're ready for high intensity exercise, or, oh gosh, I think the disease has progressed to the point you're not going to be able to do the high intensity exercise. We're going to move you to skilled maintenance. But if someone makes it into the high intensity exercise route, which we anticipate many patients, even HOEN-YAR stage 4, which is significant disability and requiring an assistive device, we anticipate these patients can still do high intensity exercise. I don't have time today, but there is a wonderful video in New England Journal of Medicine showing a patient with Parkinson's who can't walk, but can still ride a bike completely fluidly. It's one of the mysteries of this disease. But anyhow, in the high intensity exercise pathway, we do a cardiopulmonary exercise test to generate an individualized exercise prescription, and then connect that patient with an exercise physiologist who will be their individual coach to help implement the prescription. And then we have annual follow-ups where we do a physical therapy reassessment and determine things are good to go, or I think you need a course of restorative physical therapy along with the continuing in the high intensity program. So that is a sketched outline of what we're working to implement. The other thing I want to highlight about our program is we're embracing this idea of group education. Again, given the overwhelming demand for services because of the growing number of patients with Parkinson's, for early in the disease course, patients often don't necessarily yet need individualized speech language pathology or occupational therapy. And so in our interdisciplinary days, when we bring a whole bunch of patients together at the same time, we're actually starting the day with some group education from our neurophysical therapist and our exercise physiologist. And then over lunch, having all the patients together and giving rotating talks by nutrition, occupational therapy, speech therapy, so that we can provide group education and really empower patients to start to know what's out there. Now, when a patient may get to a later stage of disease and have trouble swallowing, yes, they need an individual, barium swallow, speech eval, and things like that. But this is, one idea we're trying to really try to meet the growing demand. So, in summary, with this program, our solutions to the problems of access are really, we are shifting the site of care from sort of all depending on a movement neurologist to this team-based approach to care, where the physical therapist and the exercise physiologist and the Parkinson's nurse are really going to assume ownership of that patient, and it will reduce the number of times they have to see the physician, especially early in the disease. And then the physicians can get more people in to make the diagnosis to get them into the program. The second thing we're doing is we're building these orbits and trying to integrate care for our patients. I didn't mention this, but we are establishing connections out into that third orbit as well. And then, for the third problem, we're implementing exercise as medicine, and it's not easy, and I'm sure we'll learn a lot as we go along. But we have a great team at Park City Hospital, and I think it's a great place to start piloting this project. So you may be wondering, this all sounds great. How are you going to pay for this? And that is a very fair question, and I think crucial to any kind of process improvement work. So we have a generous philanthropic donation to get us started, and we're running several studies to understand our current economic state, measure our costs going forward, and then we'll work with our integrated payer Select Health to propose a bundled payment for the services that are listed on this slide. By keeping the cost the same as what's already being spent, but cost shifting away from the physician to rehab and exercise, we'll be able to provide better care for the same cost and be able to get more patients in. And so by creating this novel payment mechanism, we won't have to rely on philanthropy. We'll be able to fund the program in perpetuity, through traditional insurance. Certainly, we feel very fortunate at Intermountain that we have an integrated payer called Select Health. This insurance company, Select Health, is literally part of our health system. And so we're working with them along the way to get the data that we need to make this a reality. And I'm also thrilled to be working with Dr. Miriam Rafferty from the Shirley Ryan Ability Lab. She's a PhD neurophysical therapist and an implementation scientist. And we're currently applying for external funding to better understand the current utilization and costs of rehab services at Intermountain, as well as to look at retrospectively collected outcome data that we have in our robust rehab outcome measurement system here. Because interestingly, although there have been several prior published economic analyses of Parkinson's, none of them include granular costs on rehabilitation. And to me, that's crazy considering rehabilitation is a cornerstone of proper treatment for Parkinson's. And so big picture, the hope is that if we're able to successfully craft and fund the Parkinson's Elevated program here, it could spread, hopefully beyond Intermountain Health. So with that, I'll conclude my talk. Thank you so much for listening, and I'm very much looking forward to the discussion.